So case management of diabetic ketoacidosis in HHS are extremely important because practical implementation of the protocols is essential. So we'll go through a few cases in terms of diagnosis and management of these conditions. So this was a 3-year-old boy with asthma who was admitted in the ICU with severe asthma, received beta agonist, terbutaline, was found to have a high blood sugar with metabolic acidosis. So a reference was given whether this actually is diabetic ketoacidosis or not, because the treating team was considering that this child may have DKA as the primary diagnosis, which has resulted in the presentation with a asthma-like situation. So is it diabetic ketoacidosis? So diabetic ketoacidosis is basically a triad of diabetes, ketosis and acidosis. And what we are seeing here is that there is diabetes and the sugar levels are not very high as usually seen in the setting of first presentation of DKA. There is acidosis, but what about the third most important component of ketosis? So we ordered for ketones which were found to be negative, which goes against the diagnosis of DKA in this setting, and this is characteristic of stress hyperglycemia. And what should be done in this setting is to look at HbA1c, and if the parents are very concerned, we can look at the antibody status and C-peptide, because there is a risk of development of type 1 diabetes in these children subsequently, as stress hyperglycemia may be the initial manifestation or unmasking of early diabetes which may develop later on. So one needs to be very cautious in these children about development of type 1 diabetes subsequently. This 1-year-old boy presented with failure to thrive, had metabolic acidosis which was high anion gap, had ketones, but blood sugar levels were varying between 80 to 200 without using insulin. So there is a child who definitely has in this setting ketosis and acidosis, but hyperglycemia is not very clear. So in this setting, one needs to be very careful in terms of possibility of organic acidemia, which was basically suggested because the HbA1c level was also normal, and further workup was confirmatory of organic acidemia in this setting. 4-year-old child with severe DKA was managed as diarrhea in a peripheral center and was referred, and the at presentation had severe metabolic acidosis with pH of 6.8 and a ketone of 7.1. She had drowsiness, anisocoria and breast reflexes. And this is one setting where one needs to keep the eyes and ear open for the possibility of cerebral edema at diagnosis. Although characteristically cerebral edema develops by around 6 to 12 hours of treatment, it may actually be present even at diagnosis, and in this setting, giving immediate mannitol and a gradual correction is essential. So children who have been treated outside via peripheral team, one needs to be very careful in terms of the amount of fluid which is used, and that fluid has to be reduced in the management, and there is a high risk of development of cerebral edema at presentation, and a careful GCS evaluation along with cranial nerve examination, pupils and DTR is essential to exclude cerebral edema. 3-year-old boy with severe diabetic ketoacidosis, again managed in a peripheral center with diabetic ketoacidosis, presenting with severe metabolic acidosis with pH of 6.9 and bicarb of 5. What is very important here is to really look at the potassium level, because two conditions which are very common in a peripheral management is the development of cerebral edema and hypokalemia. And what was found in this setting was the potassium levels were 2.8. So definitely this child is at a high risk. If we start insulin infusion in this child, he will go into severe hypokalemia and may even cause cardiac arrhythmia. So in a peripherally managed child with a potassium of 2.8, one needs to basically start potassium in the hydration phase at 20 millimoles per liter, and only when the potassium levels are going above 3.3 or 3.5, one needs to really start insulin at that point of time. So now we'll talk about this girl who is 10-year-old, presented with severe hyperglycemia, metabolic acidosis and 10% dehydration. So how do we decide about treatment of this child? So first of all, since there is severe metabolic acidosis, it's best to manage the child in the setting of intensive care unit. We'll now decide about the fluid requirements, which will include the maintenance and deficit over a period of 48 hours because there are no clear-cut features of cerebral edema in this setting at the moment. So as per the SPAT protocol, the 421 rule, her fluid requirement is 70 ml per hour for the maintenance, and considering a 10% dehydration, it is 65 ml per hour over a period of around 48 hours. So a total fluid requirement would be 135 ml per hour. Now just to compare as to how BSPAD comes in the picture, in this regards the upper limit is 40 ml per hour. So it's 30 ml per hour lower. Since the pH is less than 7.1, we anyway assume the same level of dehydration. The requirement becomes 105 ml per hour. So there is around 30% reduction as far as fluid requirement for the BSPAD protocol, which may slightly prolong the duration of therapy but reduce the risk of development of cerebral edema. So we'll consider giving a bolus because this is a sick child, normal saline followed by infusion as per the SPAT protocol with 40 millimoles per liter of potassium chloride. If potassium phosphate or potassium acetate is available, part of potassium can be supplemented with that, and insulin should be started with 50 units in 50 ml at the rate of 3 ml per hour. So now on follow-up at 4 hours, this child's blood sugar is still high. We expect 150 decrease within 1 hour of hydration, and then further insulin maybe another 200 decrease, but it's not decreasing and the base excess is still high. So what is happening? Why is this child not improving? This could be because of too little insulin, too dilute insulin, or the insulin which is bound to tubings. So therefore we need to re-prepare the whole solution, flush it around 15 to 20 ml and then restart the infusion. And if it is persistently not improving, one should think of a possibility of hemodynamic instability and shock. At 8 hours, the child has now improved. The blood sugar is 190 and metabolic acidosis, however, is persisting. So this is a very common situation where blood glucose can improve earlier, but acidosis is persisting. So in this setting, since the blood sugar is less than 200, we need to add 10% dextrose along with continuation of insulin. At 10 hours of therapy, blood sugar becomes 220. There is still some metabolic acidosis. We have added dextrose, but there is hypokalemia. So there's persistent acidosis, dextrose was added, but there is development of hypokalemia. And now the main question is, what do we do with this hypokalemia? What we need to understand that the major concern for this child at the moment is the potassium level of 2.6 and not the base excess of -11. If the child is going to have a complication, if the child is going to die, it is because of hypokalemia and not because of this level of acidosis. So in this setting, it's really prudent to reduce the insulin dose because it will slightly prolong the duration of DKA therapy, but at least will avoid the development of severe hypokalemia. So insulin dose should be decreased and potassium infusion can be increased. At 14 hours, the child suddenly becomes comatose, which is in the setting of severe DKA. Rapid fluctuation in sugars, osmotic shift is direct pointer towards cerebral edema, and one should immediately give mannitol in this setting. Mannitol or 3% saline and 10% dextrose should always be on the bedside of a child with diabetic ketoacidosis. Mannitol has been found to be superior in terms of outcome as compared to 3% saline, and we should not wait for imaging, and that will be lethal in this condition. 20 hours after treatment, the child is better, blood sugar is 190, base excess, however, is still persisting. So why is this child having persistent metabolic acidosis? And to answer this, we need to really think of three possibilities. Whether it could be persistent ketoacidosis, there is some other cause like renal failure or lactic acidosis, or finally, is it hyperchloremic metabolic acidosis because of excessive sodium chloride which is being given? So we need to look at ketone levels, which were low. So in the setting of low ketone, normal urine output, no evidence of infection, hemodynamically stable child, it's unlikely to be DKA, which is persisting, or a lactic acidosis. We should look obviously at the setting to anion gap, which was normal. So which is confirming the possibility of a hyperchloremic metabolic acidosis, which is a self-limiting condition in this regards. 28 hours after treatment, the child has a blood sugar of 170, absolutely normal, base exercise improved, child is conscious, was allowed orally, regular insulin was given, and fluid and insulin was stopped. The child, however, 2 hours later had severe hyperglycemia. So why did this happen? So this is because we did right that we did the transition when the ketone and blood gas was normal, but there was no long-acting insulin which was given a night prior, and the infusion was stopped very quickly. So in this setting, we need to continue insulin infusion for at least 30 to 60 minutes so as to get an overlap in this perspective. So this case highlights the importance of careful management and monitoring in DKA, particularly concerns about development of cerebral edema, hypokalemia, and hypoglycemia, and very careful management during transition phase to ensure good outcome in this perspective. 16-year-old boy presented with drowsiness and sugar levels of 1200. The child is obese, has severe acanthosis, has mild metabolic acidosis with low bicarb, ketone levels are marginally positive, and plasma osmolality is high. So what is this? Is it DKA or hyperglycemic hyperosmolar syndrome? This looks like type 2 diabetes, but both DKA and HHS can happen. What we are seeing is that there is severe hyperglycemia and there is hypoketosis. The blood gas shows mild acidosis, which may be because of other features like dehydration and lactic acidosis. So this is clearly a hyperglycemic hyperosmolar state. So this child is 82 kilograms, has severe dehydration and sodium of 150. So how do we manage? So first step obviously is to give normal saline bolus, which was given over 1 hour, 20 ml per kg, followed by maintenance of around 102 ml per hour as per the 4-to-1 law, and deficit of approximately 10 liters because the deficit is more in this setting of 280 ml per hour. So the fluid requirement is really huge in this setting. It should be given as 0.45% normal saline. And we should also add urinary loss as 0.45% normal saline based upon the hourly urinary replacement. At 4 hours, the blood sugar has come down 780 milligrams per dl and sodium is 145. So what do? So the sugar fall is around 105 milligram per dl per hour, which is good. We don't need to start insulin now. But the sodium fall is more. There's a rapid fall. So we should shift the child now into normal saline then N/2, which is very important. At 6 hours, the child had a blood sugar of 600, but at 4 hours it was 520. So now what is happening is that the sugar fall has come down below 50 milligram per dl per hour. So there is a slow fall of glucose. We need to check for hydration status. But in this setting, we need to also add insulin at a low dose of around 0.025 to 0.05 unit per kg per hour. At 12 hours, the child had sudden weakness and complained of muscle pain. The urinary catheter site and the urobag showed a reddish urine. There was a sudden increase in potassium and creatinine level. So what went wrong was that this is the setting of rhabdomyolysis. We confirmed with CPK levels being high. So in a child with hyperosmolar state, one needs to be very cautious about development of rhabdomyolysis because then the whole management changes and we need to treat them in the lines of adverse renal outcome, and maybe dialysis may also be required in this setting.